Conjunctiva. First, we'll discuss the glands of conjunctiva. There is mucin glands of conjunctiva. There is mucin secreting glands and accessory lacrimal glands. Mucin secreting glands are the goblet cells, which is unicellular glands in the epithelium, and crypts of Henle, which is present in the tarsal conjunctiva, and glands of Mans, which is present in the limbal conjunctiva. Accessory lacrimal glands are the gland of Kruse and glands of Wolfram. Here we'll see the gland of Mans and gland of Henle. Gland of Mans is present in the limbal conjunctiva, and gland of Henle is present in the tarsal conjunctiva. Gland of Henle. Then we have the gland of Kruse glands and gland of Wolfram. Gland of Kruse and gland of Wolfram. Now next plica semilunaris. Here this is a plica semilunaris here. This here. It is a pinkish crescentic fold of conjunctiva present in the medial canthus. Then we have the caruncle. This is a caruncle which is situated in the inner canthus just medial to the plica semilunaris. Next, the microorganisms which are normally present in the conjunctival sac are the Staphylococcus albus or epidermidis, then diphtheroids, Propionibacterium acnes, Neisseria catararis, and Corynebacterium cirrhosis. These are the organisms normally present in conjunctival sac. Then sometimes Streptococci, E. coli, Proteus are rarely found. Now, classification of conjunctivitis based on the response. It can be follicular, papillary, and granulomatous. Follicular, you should always remember this. It is usually seen in viral and chlamydal. If it is viral and chlamydal, then there can be in allergic also follicles can be seen, but most commonly follicles are seen in viral and chlamydal, and papillary it is seen in allergic. Granulomatous is seen in fungal, paranoid, oculoglandular syndrome, then TB, syphilis, then parasitic, foreign body, etc. Now coming to follicular conjunctivitis. Follicular conjunctivitis, it can be acute, subacute, or chronic. Acute follicular conjunctivitis is usually seen in chlamydia, epidemic keratoconjunctivitis, pharyngoconjunctival fever, Newcastle conjunctivitis, hemorrhagic conjunctivitis, and herpes simplex conjunctivitis. Subacute or chronic conjunctivitis is seen in drug-induced pilocarpine, molluscum contagiosum of lids, pediculosis of lids, and trauma to the lid. Next is bacterial conjunctivitis. These are the follicular conjunctivitis. Next is bacterial conjunctivitis. It is the most common cause of bacterial conjunctivitis is Staphylococcus aureus, most common cause. Then most common cause of angular conjunctivitis is Moraxella lacunata, that is a gram-negative diplococci. Diplobacillus, sorry. Gram-negative diplobacilli. Then most common cause of pseudomembrane conjunctivitis is Streptococcus pyogenes. Epidemic of mucopurulent conjunctivitis, that is red eye, is caused by Haemophilus aegypticus, that is Coquelic's bacillus. Now acute membranous conjunctivitis, that is it is caused by Corynebacterium diphtheria, acute membranous conjunctivitis. Colored halos are most commonly seen in acute mucopurulent conjunctivitis is because of due to the flakes of mucus passing across the cornea. Okay. Treatment is topical antibiotic in bacterial conjunctivitis, topical antibiotics, irrigation of conjunctival sac, dark goggles, etc. can be given. In irrigation of conjunctival sac can be given. Contraindication is bandage and steroids. Next is acute membranous conjunctivitis. Acute membranous conjunctivitis, nowadays it is very rare because of markedly decreased incidence of diphtheria. Typically it is caused by Corynebacterium diphtheria, and occasionally it can be caused by Streptococcus hemolyticus. It is inflammation of the conjunctiva associated with deposition of the fibrinous exudate on the surface, resulting in the formation of true membrane. Okay, true membrane is tough and firmly adherent to the conjunctiva, and it bleeds on removal, leaving a raw area, usually covers a palpable conjunctiva. Pseudomembrane can be easily peeled off, leaving behind intact epithelium and do not bleed. That is pseudomembrane. Then treatment topically we can give penicillin eye drops, or anti-diphtheric serum topically can be given. Next we will discuss about ophthalmia neonatorum. Ophthalmia neonatorum, the based on the time incubation period, the causes can be in for one. If it is like within 4 to 6 hours, then causes usually chemical. No treatment is required. If it is within first 48 hours, causes usually gonococci. We can give saline lavage, ceftriaxone or cefotaxime IM and bacitracin eye ointment. If it is within 48 to 72 hours, that is within 2 to 3 days. This is like within 2 days. Gonococci is within 2 days. If it is 2 to 3 days, then it is usually due to other bacterium like Staphylococci, Streptococci pneumoniae. It can we can give neomycin or bacitracin eye ointment. Then if it is like 5 to 7 days, that is almost 1 week, up to 1 week, then the cause can be herpes simplex virus 2. We can give aceclovir 3% eye ointment. Then 5 to 14 days, that is 1 to 2 weeks. Then the cause can be neonatal inclusion conjunctivitis. The treatment can be, we can give is topical tetracycline or erythromycin. Now chlamydia trachomatis is the commonest cause of ophthalmia neonatorum in developed countries. Okay. Next is paranoid ocular glandular syndrome. Paranoid ocular glandular syndrome, the cause can be numerous causes are there like tularemia, cat scratch, TB, syphilis, lymphogranuloma venerum, etc. Here it is characterized by unilateral granulomatous conjunctivitis will be there, and preauricular lymphadenopathy will be there, and fever will be there. These are the unilateral granulomatous conjunctivitis, preauricular lymphadenopathy and fever. That is paranoid ocular glandular syndrome. Trachoma is chronic keratoconjunctivitis. The causative organism is Chlamydia trachomatis. It belongs to Psittacosis lymphogranuloma trachoma group. Psittacosis lymphogranuloma trachoma group. Female sex is more commonly and severely affected. Then common in areas of dry and dusty weather. Transmission, it is direct spread, flies, material, direct spread. This is a transmission, direct spread, flies, material transfer. Symptoms, then incubation period is approximately 5 to 21 days, is approximately 3 weeks. Trachoma dubium is early stages. Trachoma is indistinguishable from bacterial conjunctivitis, that is known as trachoma dubium. Early stages, trachoma is indistinguishable from bacterial conjunctivitis. Clinical features, symptoms include initially the patient will have mild foreign body sensation, lacrimation, stickiness of eyelid and scanty mucoid discharges. Chronic infection and sequelae include pain, photophobia and loss of vision. This is in case of chronic cases. Pain, photophobia and loss of vision will be seen in chronic cases. Now conjunctival sign, coming to conjunctival signs. In conjunctiva there will be follicles. Conjunctival follicles will be there. It is most commonly seen in upper tarsal conjunctiva and fornix. Follicles on bulbar conjunctiva, if at all it is seen, it is pathognomic. Okay, pathognomic of trachoma. Follicles on bulbar conjunctiva. Follicles on bulbar conjunctiva is pathognomic of trachoma. Then follicles are aggregations of lymphocytes, histiocytes and multinucleated cell, that is the Leber cells. Papillary hyperplasia can be seen. Then this venous scar in sulcus subtarsalis is known as Art's line. Concretions, these are accumulation of dead epithelial cells. Concretions is a accumulation of dead epithelial cells plus mucus in the depressions called glands of Henle. Here in glands of Henle, these dead epithelial cells and mucus, inspissated mucus in depressions are called, glands of Henle are called concretions. Now corneal signs. Corneal signs include Herbert follicles, that is follicles in the limbal area, that is known as for Herbert follicles. Then pannus, that is infiltration of cornea with vascularization, that is called pannus. And corneal ulcer and opacities can also be seen. These are the corneal signs. Okay. Now disease and organism, coming to the diseases. This hyperendemic trachoma is caused by Chlamydia trachomatis A, B, BA and C. The transmission is eye to eye. Then paratrachoma, that is neonatal and adult inclusion conjunctivitis. The organism is Chlamydia trachomatis D to K. The transmission is genitals to eye. In case of lymphogranuloma venereum and conjunctivitis, organism is Chlamydia trachomatis L1, L2, L3. Transmission is again from genitals to eye. Now, coming to WHO classification of trachoma. Trachomatous inflammation, that is follicles. Here there will be 5 or more follicles, approximately 0.5 millimeter in size on the superior tarsus. That is follicle here. Here you can see these follicles. The criteria is there should be 5 or more follicles of 0.5 mm in size. Then trachomatous inflammation, intense inflammation, there is diffuse inflammation of the tarsal conjunctiva and more than 50, obscuring more than 50% of the vessels. Deep tarsal, normal deep tarsal vessel and papillae are present. Here this is a trachomatous inflammatory stage. Now next is trachomatous scarring, that is visible scar. Here, trachomatous scarring, that is only easily visible fibrous white tarsal bands can be seen. Now next is trachomatous trichiasis, that is at least one lash touching the globe, and last one is corneal opacity. These things you should remember: more than 5 follicles, 0.5 mm follicles, and trachomatous more than 50% vessel should be obscured. In scarring, then trachomatous trichiasis at least one eyelash should be turning inwards, and corneal opacity. Last is corneal opacity. That is a WHO classification. Now diagnosis is by detection of inclusion bodies. Culture of Chlamydia trachomatis in McCoy cells. This is diagnosis by detection of inclusion bodies and culture of Chlamydia trachomatis in McCoy cells. Okay. Now treatment, coming to treatment, topical antibiotics tetracycline, erythromycin or sulfacetamide can be given, tetracycline. Then systemic tetracycline, erythrodoxy or azithromycin can be given. As tetracycline is teratogenic, azithro is preferred in pregnancy. Now complications and sequelae. Only complication is corneal ulcer. In lids it can lead to trichiasis, andropyon, tylosis, that is thickening of lid margin, ptosis, medarosis, and ankyloblepharon. In conjunctiva it can lead to concretions, cirrhosis, symplepharon. Cornea can lead to corneal opacity, ectasia, cirrhosis, or total corneal pannus can also be seen. Then chronic dacrocystitis can also be a sequelae. Now prevention is by safe strategy, that is surgical correction to correct any lid abnormality. Lid abnormality can be corrected. Then antibiotics, azithromycin 20 mg per kilogram up to 1 gram single dose should be given. That is a treatment of choice. Azithromycin 20 mg per kilogram up to 1 gram, that is a single dose is given. Other drugs are erythromycin, tetracycline, doxycycline. Then F for facial, S surgery, A antibiotics, F for facial hygiene, and E for environmental improvement. That is trachoma. Next, coming to allergic conjunctivitis. Allergic conjunctivitis, it is also known as spring catarrhal or vernal keratoconjunctivitis. It is a recurrent bilateral interstitial self-limiting allergic inflammation of conjunctiva with seasonal incidence. It is a type 1 hypersensitive reaction to pollens and other exogenous allergens. Okay. To pollens and other exogenous allergens. Clinical features include it is usually seen in boys, mostly 4 to 20 years. More common in summer, also known as warm weather conjunctivitis. There is marked burning and itching sensation. Photophobia, lacrimation can be seen in severe cases. Photophobia, lacrimation. There is this ropey discharge known as Maxwell-Lyon sign. Now the palpable form has have cobblestone or pavement stone appearance. Papillae hypertrophy is here. These papillae hypertrophies to produce cauliflower like excrescence of Jane papillae hypertrophies. Next is bulbar form for have the horner. This is bulbar form. Form horner taranda spots along the limbus here. No picture is here. These are the horner taranda spots across the limbus. These are the giant papillae. These papillary hypertrophies. Papillary hypertrophies causes is cauliflower like excrescence. These are of giant papillae. Now in cornea, there can be corneal signs include punctate epithelial keratitis, shield ulcer and pseudogerontoxin with a cupid bow outline. This is a pseudogerontoxin here, and this here is a pseudogerontoxin with a cupid bow outline here. Now, treatment of allergic conjunctivitis spring-catarrhal include topical steroid, mast cell stabilizer, that is sodium chromoglycolate should be given. This is an important one. So mast cell stabilizer, sodium chromoglycolate. Then topical steroids in severe cases, acetylcysteine. Again in severe cases, it is a mucolytic. Acetylcysteine can be given, and cyclosporine in unresponsive cases can be given. In unresponsive cases, cyclosporine can be given. Next is Flictenula keratoconjunctivitis. It is an allergic response of cornea and conjunctiva to endogenous allergen. Okay, cornea and conjunctiva to endogenous allergen. It is a type 4 hypersensitive reaction. Allergens include tubercular proteins, that is the most common, then staphylococcal protein and Moraxella axenfil bacillus, and worm infestation can also cause Flictenula infestations. Can also cause Flictenula keratoconjunctivitis. Incidence highest in summer and spring. Age group is 3 to 15 years. Girls are affected more than boys. There is presence of this pinkish white nodule here, this pinkish white nodule which is surrounded by hyperemia on the bulbar conjunctiva, usually near the limbus. Okay, there is no itching. Okay, in this in Flictenula there is no itching. Cornea, there can be sacrophilous ulcer, vesicular ulcer and mealy ulcer. Sacrophilous ulcer is the most important. Then treatment is topical steroids, antibiotics and atropine can be given if cornea is involved. If cornea involved. Next is giant papillary conjunctivitis. Giant papillary conjunctivitis is a localized allergic response to contact lens, prosthesis, left out nylon switches, etc. Next is coming to ophthalmia nodosa or caterpillar hair conjunctivitis. It is a granulomatous inflammation of conjunctiva. Granulomatous inflammation of conjunctiva forming a nodule on the bulbar conjunctiva. Here it forms a nodule on the bulbar conjunctiva in response to irritation caused by a retained hair of caterpillar. And this is the name also, ophthalmia nodosa or hair caterpillar hair conjunctivitis. Treatment is excision biopsy. You have to do excision biopsy. Next, coming to viral conjunctivitis. Epidemic keratoconjunctivitis caused by adenovirus 8 and 19. Pharyngoconjunctival fever is caused by adenovirus 3 and 7. And acute hemorrhagic apolloconjunctivitis caused by enterovirus 70. This you should remember. Epidemic 8-19 adenovirus, pharyngoconjunctival fever 3-7 and acute hemorrhagic apolloconjunctivitis caused by enterovirus 70. Now coming to conjunctivitis, it can be either bacterial, viral, allergic and chlamydial. In bacterial, the congestion is marked and chemosis will also be there. Bacterial, the discharge is purulent or mucopurulent. In viral, it is watery, and allergic, it is ropey or watery, and chlamydial, it is mucopurulent discharge. Now papillae is present in allergic conjunctivitis, and follicles is present in viral and chlamydial. Pseudomembrane can be present in this bacterial or viral. Then preauricular lymph node is present in viral conjunctivitis. Neutrophils are seen in all except allergic. In allergic, eosinophils are seen. And inclusion bodies, chlamydia can be seen, and in pox and herpes viral infection also inclusion bodies can be seen. These are the important points about HIV and everything. Here PANS, and one more thing, PANS will not be present in anything except for allergic, except in VKC. Only in allergic VKC we can see PANS. Other conjunctivitis, PANS won't be present. Next is ocular cicatricial pemphigoid. It is also known as ocular mucous membrane pemphigoid. Ocular cicatricial ocular mucous membrane pemphigoid. It is a type 2 hypersensitive reaction involving the basal membrane of epithelial cells of conjunctiva. See, it involves conjunctiva in majority of cases and causes progressive scarring and cicatrization. Conjunctiva is involved in majority of the cases and causes progressive scarring, that is cicatrization. Typically it presents in old age, that is more than 50 years. Typically in old age, it affects females more than male in a ratio of 2:1 ratio. There is a insidious or relapsing remitting non-specific bilateral conjunctivitis. Either insidious or relapsing remitting non-specific bilateral conjunctivitis will be present. There is symblyferum formation, that is addition between the bulbar and palpebral conjunctiva. That is symblyferum formation will be seen. Here symblyferum formation, flattening of the plica and keratinization of the caruncle can be seen. Flattening of the plica and keratinization of caruncle. The dry eye is a feature due to destruction of goblet cells and accessory lacrimal glands and occlusion of the main lacrimal ductils. Because of this there is dry eye. Sometimes there can be ankyloblepharon also. Ankyloblepharon, adhesion of the outer canthus between the upper and lower eyelid can be seen in severe cases. The adhesion between the two eyelids is known as ankyloblepharon. Adhesion at the outer canthus between the upper and lower eyelid can be seen. Corneal infiltration and peripheral vascularization can be seen in severe cases. Corneal infiltration, peripheral vascularization, keratinization and conjunctivalization of the corneal surface. Of corneal surface, keratinization and conjunctivization of corneal surface. Now treatment include systemic, dapsone, antimetabolites and steroids. Topical, artificial tears like methyl cellulose or hypomethyl cellulose. Steroids and retinoic acid can be given. That is ocular cicatricial pemphigoid. Next we will go to degenerative condition. First is pincugula. Pincugula is a white, yellowish white. Here you can see this yellowish white, triangular patch on the bulbar conjunctiva near the limbus. It is seen. It is elastotic degeneration of collagen fibers of the substantia propria. Elastotic degeneration of the collagen fibers of the substantia propria, usually bilateral, stationary and nasal side affected first, can become pterygium. Okay, that is pincugula. Next is pterygium. Pterygium, it is a fold of conjunctiva encroaching upon the cornea from either side within the interpalpable fissure. This is pterygium. It invades the corneal epithelium, involves corneal epithelium, Bowman's layer and superficial stroma. Corneal epithelium, Bowman's layer and superficial stroma, fold of conjunctiva encroaching upon the cornea from either side within the interpalpable fissure. Clinical features include elderly males usually doing outdoor activity, usually on the nasal side. Symptoms include mostly it is cosmetic. Then other symptoms include defective vision, foreign body sensation, diplopia, etc. Most small lesions are asymptomatic. Lesion may interfere with vision and by obscuring the, here it can obscure the visual axis and or inducing it can induce astigmatism. The lesion may interfere with vision by doing this. Then iron deposition. The iron deposition seen in the anterior head of the pterygium. This is iron deposition seen in the anterior head of the pterygium is to the head of regressive pterygium. This is known as Stalker's line. Stalker's line. Fuchs highlights is there, something called Fuchs highlights. These are small discrete whitish flecks often present at the advancing edge. Those are known as Fuchs highlights. Small discrete white flecks often present at the advancing edge. Complications include cystic degeneration. Then rarely neoplastic changes can be there, very rarely. So treatment is surgical excision. That surgical excision, but recurrence rate is about 30 to 50%. Recurrence reduced when surgical excision is combined with free conjunctival limbal autograft. It is a preferred technique now. It is with least recurrence, or we can give or surgical excision can be combined with amniotic graft and mitomycin C or Thiotipa application for recurrent and late pterygium. Then lamella keratectomy or lamella keratoplasty for deeply infiltrating recurrent recalcitrant pterygium. Infiltrating recurrent recalcitrant pterygium, we can do this. Pterygium involving the pupillary area. Now Macronol's operation and postoperative beta irradiation were old techniques. It is not used now. Now pseudopterygium, it is caused by a band of conjunctiva adherent to an area of compromised cornea at its apex. It forms as a response of inflammatory episodes such as chemical burns, corneal ulcer, especially if it is marginal, and trauma, and cicatrizing conjunctivitis. It can occur at any site. A probe can be passed under the pterygium. In case of pseudopterygium, probe can be passed under its neck. In pterygium, probe cannot be passed. That is how we differentiate. Here, so probe can be passed in pseudopterygium. In pterygium, probe cannot be passed under the neck. Next is conjunctival cirrhosis. Conjunctival cirrhosis is nothing but dry and lustreless conjunctiva. Lustreless dry and lustreless conjunctiva. Types, it is of epithelial cirrhosis, hypovitaminosis A, and or parenchymatous cirrhosis. Now parenchymatous cirrhosis can be destructive interstitial conjunctivitis like trachoma, Stevens-Johnson syndrome, or ocular cicatricial pemphigoid or pemphigus, prolonged beta use, or thermal chemical radiation, or diphtheric membranous conjunctivitis, or it can be due to exposure of conjunctiva to air, such as in marked proptosis, facial palsy, ectropion, lack of blinking coma, or lack of thalamus. That is parenchymatous cirrhosis. Next is xerophthalmia, that is epithelial cirrhosis, that is hypervitaminosis A. The WHO classification of epithelial cirrhosis is the XN is for night blindness, 1A for conjunctival cirrhosis, B can remember as Bitot spot, 2 corneal cirrhosis, 3 corneal ulcer less than 1/3, 3B more than 1/3, XX for corneal scar, and XF for xerophthalmic fundi. Now for prophylactic vitamin E doses, 1 lakh international unit at 9 months with measles immunization, 2 lakh at 16 to 18 months with DPT booster, and 2 lakh every 6 months up to the age of 5 years. Now a total of 9 mega doses are given to the are to be given from 9 months up to the age of 5 years. Now coming to subconjunctival hemorrhage. Subconjunctival hemorrhage in children is usually seen in case of whooping cough, scurvy, bleeding disorder, and malaria. Whooping cough, scurvy, bleeding disorder, and malaria. Then Kaposi sarcoma, it is a bluish red. This is a highly vascular tumor. It's a highly vascular tumor and seen as a bluish red elevated nodule, resembling subconjunctival hemorrhage. That is Kaposi sarcoma. Then next one more is like conjunctival cyst. Conjunctival cyst, that is a common cause, is dilatation of limb spaces, lymphangiectasia, lymphangiomata on the bulbar conjunctiva. Lymphangiectasia, lymphangiomata on the bulbar conjunctiva. Larger retention cyst of cross axillary lacrimal gland can occur in the upper fornix and subconjunctival cysticercosis and hydatid cyst are very rare. Okay.